Yeah, so we're having Dr. Mwangi from Kenya. So she's joining us also on the webinar. We have Mr. Anu Samuel from Accra, Ghana. Likewise, we have Charity Monareng from South Africa. So we'll be starting up in a few minutes because we always try to wait for our colleagues, our peers who might be having network issues joining in. So we always give a grace of 5 to 10 minutes to have a reasonable number of participants before we kickstart. So, and I'm really excited for this section, and I'm sure a lot of my colleagues are also excited. So, but before we go ahead, I would like to take us through Students for Sensible Drug Policy in Africa and globally, and all what we've been doing towards ending the war on drugs. So at Students for Sensible Drug Policy, we believe the war on drugs is a war on us. And we have been doing this for over 2 decades, and we are committed to empowering young people with the needed knowledge to participate in the political process for pushing for sensible policies to achieve a safer and more just future. We fight back against counterproductive drug war policies, particularly those that directly harm students and young students and students. So we advocate to end the drug war, become an expert in promoting sensible drug policies, protecting our communities, educating our peers with needed tools to become great advocates for drug policies, connect with leaders around the globe to make sure the world is a better place for all of us, defend justice, and that we change the world, and we always want to make sense. And we have thousands of members across the globe. We have a vibrant community in Africa, and currently we are the largest drug policy network, young network in Africa, and we have partners across South Africa, East Africa, West Africa, and Central Africa. And on this note, permit me to welcome you officially to this month's webinar, which is geared at educating the young populace in Africa. And our topic is harm reduction, a panacea for a safer society. Our first speaker is going to be Dr. Mwangi. Dr. Mwangi Catherine is a public health specialist with special focus on harm reduction. She has over 10 years experience implementing and managing harm reduction programs at the national and community level in Kenya and around Eastern Africa. She is a researcher and mentor to girls and women who use drugs in Kenya through an organization called Women Nest. She's versatile in the area of drug use among women and girls, and she's very skilled in the area of harm reduction, and that is why we are very glad and happy to have her here. And she would be sharing our wealth of experience in the area of harm reduction to all of us here. Permit me on this note to welcome Dr. Catherine Mwangi to the floor. Welcome, Ma. You have the floor, Ma.
Thank you very much for the welcome and for the introduction. And welcome to all the participants in this webinar. I need to share screen. I'm not able to share my screen. I think it's disabled on the other side. And today I will be talking about harm reduction substances. Okay.
So would
I just
be looking forward
to. You should be able to screen share now.
Can you hear me?
Yes, we can.
Okay.
Thank
You very much. If you can hear me, I think I can hear you clearly. Thank you very much for the introduction, and welcome to all the participants who have come in. I will be covering a topic on psychoactive substance use and harm reduction. Thank you. Do I need to continue?
Yes, ma, you can continue, ma. You have the floor, ma. You can continue.
With the presentation?
Yes, ma. Yes, you can.
Okay. Thank you. Thank you. Thank you. Thank you. So as I've explained, we are going to look at psychoactive substance use and harm reduction. And to start with, we are going to look at what psychoactive drugs are, as you can see from my screen, psychoactive drugs are any chemical substances which, when taken into the body, alters the function physically and or psychologically. That's according to WHO. And we are saying that psychoactive drugs interact with the central nervous system, and they affect the mental processes and behavior, perceptions of reality, and level of alertness, response time, and perception of the world. A very important definition there. So an overview of the psychoactive drugs that we have, they are categorized into three. We have the depressants, we have the stimulants, and we have the hallucinogens. And depressants actually suppress and inhibit or decrease the brain activity. That is the central nervous system. We have the stimulants and psychostimulants that act on the central nervous system, but these ones increase the alertness, heighten the arousal, and cause behavioral excitement. For hallucinogens, these are a class of drugs that cause profound distortion in a person's perception of reality, otherwise known as hallucinations. But the most important thing about these three groups of psychoactive drugs is that among people who use drugs, these drugs are used, there is what we call polydrug use, using more than one drug. Sometimes you find people using alcohol, then benzodiazepines, then opiates like heroin. Other times, people are going to use stimulants and depressants together. Other times, they are going to use the three of them together. So these three groups are very important to us. So among the depressants, one of the most important ones for public health and for people who use drugs are the opioids. And among the opioids, as you can see in the figure here, given by the World Drug Report of 2019, you realize that we have the opiates, which are the naturally occurring. They are naturally occurring, they are from the opium poppy. Those are the opiates. Then we have the pharmaceutical opiates. And among the opiates, you can see we have the heroin, morphine, and opium. Then we have the pharmaceutical opiates, which are the codeine and the others. We also have methadone, pethidine among the pharmaceutical opiates. Then we have the synthetic opiates, where now we have the others. But when we come to the drug controls, we find that tramadol is not under drug control. So when it is not under drug control, is that we can find it in our pharmacies, and it can also be easily abused. So for us, among the depressants, opiates are very key, because you realize that opiates are injected. Like heroin, we have heroin in our countries, and this heroin is injected, as well as the other drugs. And with the injection, they cause a lot of overdose. Then if we look at this next figure, we look at the use of these opiates and opiates. That is the synthetic ones, the opiates and the opiates, the synthetic and the pharmaceuticals, and the naturally occurring the opiates. So by 2017, if you look at this Let me put on slideshow. So this is the slide which is on slides to show so that it's more clear now. If you look at Africa, which is of our interest, you can see we have the annual prevalence by percentage. We have the opioids like heroin in Africa, East Africa, North Africa, South and Southeast Africa, West Africa, Central Africa. And of course, with all these other regions in the world, the same case with the opiates. We have them in Africa, North Africa, West Africa, and Central Africa at quite a bit. Like if you look at the opiates, the heroin, we have a lot of, we have quite a bit of it as compared to the other countries. We can say they have more, but in our continent, Africa, we also know that we have paucity of data. We have limited data, limited data. So when you don't have data, sometimes you don't know whether your figures are very high or very low, but we know that they exist from this map here. And this was from the UNODC responses from the annual questionnaire. And it really opens our eyes that for opiates, which are public health problem, we did have an issue. Then when you look at the stimulants used by region, we see that even in Africa, we have cocaine, we have methamphetamines, we have a cocktail of them, but among all the regions in the world, Africa is there, we have the stimulants too. We have cocaine and all the others, and as we said, they are also used in polydrug use. Then we look at the hallucinogens. This one is about the global seizures, people who were arrested trying to traffic on the hallucinogens. We find that there was a 7 times increase in hallucinogens trafficking, excluding ketamine. There was a decrease in ketamine, there was an increase of cannabis herb and cannabis, a decrease by that 1% of the cannabis they've seen. This is very important to us because it still shows us that a trade exists where people profit from the sale of the hallucinogens, just like the other drugs. And there was an increase. This is the World Drug Report of 2019. Then among the hallucinogens, cannabis is very important to us. We know for people who use opioids and other drugs, this is used as a polydrug. It's used together with heroin, it's used together with other drugs. So if you look at this figure here, the quantity of cannabis that was seized in the region is as that. We can see we even have in Africa, the cannabis the seen and the cannabis have both of them. We can see the presentation here according to region, but we know that cannabis continues to be the most widely used drug worldwide. And according to an UNODC, it estimates that roughly 3.8% of the global population aged 15 to 64 years used cannabis in 2017. In Africa, the annual prevalence of cannabis use 2017 is 6.4% of the population aged 50 to 64, which is actually a bit higher, much higher than the global estimates. So now we look at the global overview of the psychoactive drug use. How are those drugs we've discussed used in the world? So we realized that in 2017, 271 million people used drugs. Aged between 15 to 64 had used drugs at least once in 2017. Then it is noted that there is a higher prevalence over time of use of opiates particularly. And we can see from the figure here, we had 53 million people using opiates. And there was noted an increase in Africa, Asia, Europe, and North America. And then 35 million, or almost 13% of these people suffered from drug use disorders, meaning that their drug use is harmful to the point where they may experience drug dependence or require treatment. That is what we mean by drug use disorders. They may need treatment. And if you see from the figure that I've presented here, 188 million people are using cannabis. Of course, it's the most used in the world. 53 million were using opiates. And we know opiates are either smoked, injected, sniffed, used already. Then we have the 21%. We have ecstasy here. We have cocaine here, the stimulants and the hallucinogens. Then, what about in our prisons? What is the global overview? We are saying that 1% of people in 2017 who were incarcerated, they were in prisons, used drugs at least once, and 19% past month when the survey was done. And we know that people with a history of drug use or drug use disorders form a substantial part of the prison population in some countries, including in our countries in Africa, we know that. And drug use disorders are highly prevalent among people who are incarcerated, among people who are in prisons. Then these are the global trends, number of people who use drugs and those with drug use disorders. And those with drug use disorders, if you look at this map, you can see number of people who use drugs and then number of people with drug use disorders. There are people using drugs and those who are developing drug use disorders. So if you look, this is a global overview. Over the years from 2006 to 2017, we can see that at some point there is an increase with the number of people who are using drugs and also the number of people experiencing drug use disorders. And according to the World Drug Report of 2019, they have seen an increasing drug use among adolescents and young adults, and within the population aged 15 to 64, peak levels of drug use are seen among those aged between 18 and 25. This is the situation observed in countries in most regions and for most type of drugs. And we know for Africa, we have a young population. So if we have a young population, we know that if we don't do something, most of our young people who are aged between these young adulthood ages will suffer from drug use disorders. Then among these drugs, the opiates have the greatest harm to the health users. And why? We see that according to the World Drug Report of 2019, more than 11 million people injected drugs. And people, when they inject drugs, of course, they are at risk of blood-borne viruses. And that is why we are saying that 1.4 people who inject drugs are living with HIV, 5.6 million people are living with hepatitis C, and 1.2 million are living with both hepatitis C and HIV. And that's why we are saying for opiates, they are dangerous, and they are the most dangerous among the drugs to the health or the health of the users. If you look at the diagram here, hepatitis C and opioid use disorders are responsible for most of the deaths and disability attributed to drug use. And we can see from the figure here, and that one is explained by this other figure here. So a very important focus therefore, harm reduction. Then if we look at this global opioid crisis, we can see this is another diagram just showing about these people who are arrested trying to smuggle. From 2013, there is a 14 times increase by 2017 of people who are smuggling tramadol in Central, West, and North America. That is non-medical use of tramadol. That one means that they are actually abusing it. And then, of course, the non-medical use of these other opiates here, there was a 2 times increase from 2013 to 2017 of the overdose deaths. That is another major issue about the opiates and overdose. And especially, even in our countries, we see these deaths which are sometimes go unreported. Then, when we have looked at the psychoactive drugs and now how they are used, and now we are going to look at what are the approaches that are used for psychoactive drug use and control. First, we have the supply reduction, we have demand reduction, and we have harm reduction. And for supply and demand reduction, these are midterm to long-term goals. They take time because when you have to reduce the demand and supply reduction, that one will take quite a bit of time. And they are not good. The supply and demand reduction do not address rapid transmission of HIV or hepatitis among people who inject drugs because they take so long. But for harm reduction, these are policies and programs that are aimed at reducing the harms from drugs, but not drug use per se. We are not focusing on telling people to stop using drugs, that they need to immediately stop drugs, but we are looking at the harms. And so harm reduction is the principal element of reducing harmful consequences of drug use without necessarily reducing drug use per se. The major harmful consequences are bloodborne viruses like HIV, AIDS, and hepatitis B and C, as we've seen in the previous slides. And other harms, of course, include the social cost of drug use, the economic cost of drug use, the legal aspects, dealing with the law, arrest, and all what have you, and poverty, that they also impoverish the people who use drugs. Now, we look at very quickly at the key concepts of harm reduction. It is a practical approach. It focuses on harms and not drug use. It prioritizes. It deals with the most severe harms. It is flexible. It has maximum options, that each drug user is different, and let us provide a range of options for them. Then autonomy, that we must respect the drug user decision and choice. So those are the key concepts of harm reduction. And then what are the principles of harm reduction? It recognizes the intrinsic value and dignity of human beings. It seeks to maximize social and health assistance, to minimize repressive and penalizing measures. It does not judge. So drugs and drug use as good or bad, rather than it emphasizes on reduction of drug-related harms, encourages the safer use, recognizes the competency of users to make choices and change their lives. So if a drug user says, I don't need harm reduction today, you can never force them. You need to convince them next time. It challenges conventional drug policies and their consequences. So what are the methods to reduce the drug-related harm? So what is this component of harm reduction? What is the package? First, we have the educational programs that we have to educate people who use drugs about safe methods of drug use, how to reduce risk by not sharing the needle. So the educational aspect must be there. Then we have the needle and syringe programs, not necessarily exchange, but the needle syringe programs where we give clean needles to the drug users so that they stop sharing. Then we also have the opioid substitution therapy, which include the use of methadone, buprenorphine, to address the issues of drug use and the issues of drug use, the methadone, buprenorphine, and of course others. And then we have peer-based information on safer injecting, safer sexual practices, including condom demonstration and safer injecting practices. This one happens through outreach. You can outreach to the drug using sites. You can have programs, the community programs, the harm reduction programs where this happens. So this one is done in a programmatic manner. And then if we look now, we've looked at harm reduction and how key it is for addressing the drug harms that we have seen. So what is the global overview of harm reduction? And this is a point of concern for all of us. We can see that this one is from the drug report, the harm reduction report that was produced by the Harm Reduction International in 2020. So we are saying harm reduction implementation has worsened since our last report. That's what they said in 2018. So we are seeing that the number of countries where needle and syringe programs are available has remained level. Nothing has changed. But among the number of countries with the opioid substitution therapy, agonistic therapy, decreased by 2. So 2 countries gave up on this. So we ask ourselves, with this type of situation, what happened to the so many people we've seen they're using drugs in Africa, and what can we do? What can we talk about policy? How can we bring this everybody together to understand about this drug issue? Because sometimes it's also, I always feel that we really need to bring an army among, and even among ourselves, even as young people, to come and talk about this. And we have to talk about this with information. And that's why really this is very, very important training for all of us. Because when we have information, we have power. We can convince, we can advocate. So this is of great concern to us, and especially us in Africa. If you look at harm reduction in prisons, we had seen that from the World Drug Report of 2019, that people who are in prison had used drugs at least once, and 19% had used in the past year. But what about the number of countries implementing interventions at least in prison? Because we know people who are using opiates are in prisons. People who are using heroin are in our prisons. People who are using polydrug use, they are using cannabis, they are using all these drugs together, plus opiates are in our prisons. So only 56 countries in the world have the opiate substitution therapy. Only 11 have the needle and syringe programs, and only 10 countries have both. So you can see we really have a lot of work to do to convince governments that even in our prisons, which are really accessible to many people, but at least with advocacy, with our policy change, we can have more of these programs in our prisons. And now for harm reduction in sub-Saharan Africa. This was amazing because this is what I could find. And this was just a small section of it. So we have no data. In Africa, in the programs we run, we have to know what to do about data. We need funding for research in our programs in Africa. We need to produce more data because we have limited data. Most of the data we have, it is data in other regions of the world. So as people who are in harm reduction, people who are going to advocate for policy, we need research. We need funding for our research because we can never talk without evidence. And when I looked at this data, and I was like, we really don't have much. We don't have much. And when you don't have data, you don't have evidence to make decisions. So thank you very much.
Hello, thank you very much, Doctor. Really appreciate that wonderful presentation, and I feel it's so enlightening and so educative. So I don't know if anyone has questions for Doctor, or possibly we go to the next speaker, then we can come back to Doctor at the end of the sections. Should you have any question, kindly signify by raising up your hands.
There are a few people with questions. Should I allow them to talk?
Yes, we can give them an access to.
Awesome. Okay, so first is Eddie.
You for.
Hello? Hello? Hello?
Hello, we can hear you. Go ahead, Eddie.
You hear me? So thank you very much. Thank you very much, Dr. Mwangi. But I want to know something. As a doctor, why we continue to classify cannabis as a drug when research has shown that it's a therapeutic product? So I am so confused. Thank you very much.
I would like to receive all the questions so that I can answer them all at once.
For sure. Thank you, Eddie. There we go. Now we have Monareng.
Hi, I'd like to thank all of the panelists. So my question is, why is opioid substitution therapy used instead of medication-assisted treatment? And I'm wondering if it has something to do with one term being more stigmatizing than the other.
Okay.
Awesome. Thank you, Minerva. We are next up, Wahab.
Hello. Yeah, my question is, among prisoners, is there, because this witness such that kind of stuff happen among the prisoners? That's my question.
Kaidre, I didn't hear your question because your network is not very clear.
Yeah, my question is, you said that the percentage, the prevailing rate of HIV among the prisoner, we have like 13.10%. 13.1%, the prevalence among the prisoner. The prisoner, is there any linkage copulate with each other inside the prison and they share drugs inside the prison? That's my question, man.
Can you, I wish you could write it down because still I cannot get it because from your line I cannot hear you properly, please. Could you just type it on in the chat, please? Am I the question?
All right, I think that will be our last question for this section, so we can move on to Monareng Charity. Doctor, would you like to respond to those questions now?
I can just
you.
respond because we gave them a chance to ask about classifying of cannabis. Cannabis for a long time has been classified as a drug, but we know that globally there is legalization happening of cannabis for non-medical use of cannabis in several countries. Like in the USA, we have 10 states, and we also have countries in Europe, like we know in Canada. And these are issues of advocacy because we are saying we have to change our policies on how we view some of these drugs and how we would want to deal with them. We know that for many countries, there is a lot of profit from cannabis. There are many products that are coming from cannabis, you know. So beside that, it's being classified. So we know it is therapeutic. It is used for medication. It is being cultivated in many countries. It is in some countries, it has already been legalized. But matters of classification, it is still remains like that, and it's an issue of advocacy. Then about the opioid substitution therapy and the medically assisted treatment or therapy. The opioid substitution therapy as a term is more encompassing. When we talk of medically assisted treatment or therapy, we are talking of using maybe methadone. But when you talk about opioid substitution therapy, it's the bigger picture. You can use buprenorphine, you can use methadone, all of them, it's opioid substitution therapy. It is the main words. The others are sub-words. It is not about stigma. It is not about stigma. Let me say it's that one word is, it is more encompassing, it is more whole than the others. About prisoners, I did not get your question properly. But we know research has been done even by UNODC. We can share that data later, that there are drugs in prison. We know, we have had these testimonies from people who use drugs and have been in prisons. And that's why we are advocating that more and more we need more countries, and even in Africa, to legalize the harm reduction interventions in prisons. Thank you.
Thank you so much, Doctor. Thank you so much for that broad and explanatory responses and answers to the questions asked. We'll be going to our next speaker now, who is also skilled and very informed in the area of harm reduction. And she's based in South Africa. And we all know lately in Africa, South Africa has been ahead in the area of drug policy and cannabis legalization in the continent. So, and our speaker is Charity Monareng. She's the Parliamentary and Policy Research Officer at TB HIV Care, and she's actively engaged in national, regional, and international advocacy work for drug policy reform. She's doing the final year of her PhD studies in the public law at the University of Cape Town, and she serves on the board of the South African Network of People Who Use Drugs, Stand Action, and Digital Girl Africa. Kindly permit me to welcome Charity Monareng, our second speaker for tonight. Welcome on, Charity.
Thank you very much, Manfoli, for inviting me to speak. And yeah, so I think it's very fitting that we're discussing harm reduction in the month of love, because I believe that at the heart of harm reduction is love, and harm reduction is essentially an extension of that love to people who need it the most. So whenever I'm asked to explain what harm reduction is, I always begin by saying that harm reduction is about meeting people where they are. And this includes meeting people where they are in their journey on drug use, as well as physically being with people and providing services to them directly in their places that they're based, whether it's on the streets or in their communities. So Dr. Mwangi gave a beautiful presentation on what harm reduction is, so I'm not going to repeat the overview of what harm reduction is, but also I'm just going to speak on harm reduction in Africa. So if you work in the civil society space, you will know how challenging it has been and continues to be to get governments to fund harm reduction services or even to implement the services. And this has been a problem in a lot of countries because of government's refusal to accept evidence and even influences from other countries that is stopping governments from implementing harm reduction services. And we've seen an example of that with cannabis laws. There have been moves of progress to legalizing cannabis for medical use. However, some governments have been very resistant to it because either they hide up behind the mask that big companies are going to take over. However, it also ignores the fact that cannabis for the longest time and other substances have been legal in Africa. And it was just the Western influence that made us demonize and criminalize practices that were originally not criminalized before. So harm reduction, I mean, one of the biggest achievements, however, even though there's been a lot of resistance towards harm reduction, there has been a lot of progress. So not all is lost. There's been countries that have started implementing harm reduction programs. For example, Mozambique and Nigeria in 2019 began piloting harm reduction programs, and I'm sure they've been scaling up on their services. In Senegal, we've seen a scaling up of harm reduction services. Côte d'Ivoire has started harm reduction services. So we have seen some progress happening in Africa. However, because a lot of the harm reduction services are funded by donors, the sustainability of harm reduction programs is threatened. And so civil society organizations need to continue advocating to get governments to start funding harm reduction programs so that they become sustainable and that we own our own programs. So for example, in South Africa, we have one city-funded harm reduction program, which has been running for a few years now, and more cities are becoming interested in finding out what are the effects of harm reduction because of seeing the success of one program that has been funded by the city. And so civil society organizations need to start thinking about documenting the successes of harm reduction programs and the effectiveness of harm reduction programs, excuse me. So one of the other issues that we face in Africa is that we need to start aligning our advocacy strategies with like buzzwords that are going on globally. So for example, our sustainable development goals. There's been agendas on achieving a drug-free world, an AIDS-free world. Drug-free world is never going to be possible, is not realistic. And an AIDS-free world is impossible if governments continue to ignore a large population of vulnerable people. And so we need to start aligning our advocacy objectives with achieving our SDGs. Because if governments continue to ignore a large population of people, then the world will never be able to achieve our SDGs. So civil society organizations need to start relooking at our advocacy strategies. Another way could also be looking at shifting our advocacy strategies to more advocating within communities as opposed to national level, because it seems as though at national level we get a lot of resistance and people not understanding what we want to do. And I think a lot of parliamentarians and politicians are driven by ego. And if it's not a common thing for the communities or for the citizens, it's never going to be a priority for government. And so we need to shift our strategies to advocating at community level, where we're educating communities on what harm reduction is, the effects of harm reduction, the benefits of harm reduction. And so once citizens are aware of the benefits, it will force governments to provide more of the harm reduction programs and services, because there will be a demand by the citizens. So we know it works. And once again, civil society needs to start documenting the successes. As I mentioned earlier, governments are driven by ego. And if a government is able to boast about their successes in achieving a certain goal or the success of a program, that could be a way of kind of giving them an incentive to implement harm reduction services. So in reducing risky behavior, we need to understand that for the longest time, the buzz phrase was always that cannabis is a gateway drug. But in reality, trauma is a gateway drug. And it has resulted in people participating in risky behavior. And so when implementing harm reduction services, we need to look at a person holistically. And so we can't just be providing clean needles or just providing MAT. We need to start looking at a person holistically and providing psychosocial support. And by understanding an individual for who they are holistically and understanding why they participate in risky behavior, we'll be able to slowly get to the bottom of understanding why certain people participate in risky behaviors. Education, education, education. I always say education because we tend to assume that people know things and have access to information, when in reality we could be in the same city, but a person that lives 10 kilometers away has no idea what harm reduction is, and they have no idea where to access these services. And so we need to start providing information and informing people about what is available to them. And another thing is also advocating for the creation of environments that prevent people from participating in harmful behavior or even harming themselves and communities. Thank you.
Hi, thank you, Charity. Thank you so much, Charity. And that was awesome and very detailed. Also, the floor is open for questions and remarks and contribution from the audience. You have 5 minutes to do that. If you have any question, kindly signify. Okay. So while we wait to hear from, okay, I think we have one here. Okay. I think we'll come back to these questions later. So while we wait to hear from our audience, I would like to introduce our next speaker and probably have him continue his section while we wait for questions from our audience. So our next speaker is Mr. Samuel Hanu. Mr. Hanu began his career as a staff nurse at the Accra Psychiatric Hospital in the year 2001 and rose through the ranks to the position of principal nursing officer with supervisory and management responsibilities. He is a member of the West African Drug Policy Network, a fellow of the West African College of Nursing and the Ghana College of Nurses and Midwives, where he helped develop the addiction nurse specialist curriculum and a faculty member. Mr. Samuel Hanu has educated a lot of young people in Ghana and has helped a lot of people recover from drug use disorders. Mr. Samuel has attended a lot of conferences, workshops, and luckily I was opportune to have met Mr. Samuel at the Open Society for Society West Africa course, OSIWA, held at the University of Ghana, Legon. So I'm really excited to hear from him because I know he has a lot to share to everyone tonight. Kindly permit me to welcome Mr. Samuel Hanu to tonight's section. Welcome, Mr. Samuel.
Yeah, thank you for having me and good evening to all of you. I think my co-panelists have done a good job in the earlier presentation, so mine is to just add some few details and we can go on with the discussions. Yes, so basically, how did harm reduction all came about? So in the 1981s, around the 1980s, we had the HIV/AIDS pandemic, you know, and countries came to realize that there was a high prevalence of HIV among all getting drugs. So they had two issues at hand: drug use and diseases like HIV, like just Dr. mentioned, HIV, hepatitis, and that kind of tuberculosis and that kind of thing. So how did they control the two conditions? So they said that if it's possible for us to let them use drugs safely, then we can stop the spread of HIV/AIDS among people who are using drugs. And we implemented some of these policies in some European countries. This was a success. So the HIV prevalence rate among people who use drugs dropped. So that showed that there's something that we can do to, if we have two tools at hand. I mean, by reducing one, we will make progress. So they decided to distribute have what we call institute needle exchange programs. So that's how harm reduction came to the use. So I mean, I will not bother you with this definition. Just go. So in real life, even before we enter to drug use, harm reduction have been used in our lives, everyday lives. So you jump into your car and you're supposed to put on your seat belt. Now we're even encouraging drivers to also encourage their passengers to put on their seat belts, because you know that once you're on the road, potential for crashes are high. So when there's crashes, you can be protected. Now cars are fitted with what? Airbags. So when there's a crash, the driver and other people in the car are protected. We even have what? Car seats for kids. So we'll talk about people who are riding motorcycles. We ask them to put on what? Helmets, so that when there's a crash, the harms of injury is reduced. Their heads do not crash. You know, even these days, when in Africa, it's not common, but in other European countries, when people are even riding bicycles, they put on crash helmets, so when they fall down, the extent of injury is reduced. And sometimes talk about shades. You know, so we live in the tropical part of the world where there's a lot of sunshine. So looking at the sun, the rays of the sun with your bare naked eyes can be injurious to your eyes. So we put on shades. These are all what harm reduction things we be doing in our everyday life. Then we even talk about HIV/AIDS prevention or control. So when the HIV/AIDS issue became a big issue, the world decided that they are not only could talk about that we should abstain from sex, but they give us an acronym, ABC. The A is what? Abstain. But it's not everybody who will abstain. They also said some people, you should be faithful to your partners. But not everybody will be faithful. And the last one is what? Condom use. Condom use is a harm reduction measure. So we realize that even before drug use, harm reduction was part of our everyday life and was even part of some of the measures that was instituted to control diseases like HIV/AIDS. So harm reduction and drug use are not, I mean, my previous speakers have spoken a lot about this one, so we will not talk about it, but harm reduction in drug use. So we are saying that harm reduction encompasses a number of services. And I also not talk about this because my other colleague, but some of the things I need to mention, like yeah, so sorry about that. Yeah, so something like one of the services that we do, something like drug checking. So in places like Netherlands, Holland, they have a facility where people can submit their drugs for it to be assessed, for the content of the drug to be known. And sometimes you can advise the person that this drug you are going to take, this is the content. It is dangerous, it's fatal, and these are the risks for you. So these are other services that comes under harm reduction, but I will not talk about them because of time and because so there are certain principles, and just like Charity said, for us in the advocacy field, we are saying that it is an illusion to believe that we can have a drug-free society. So for you students, when you go out there, I mean, challenge people who put out campaigns saying that we are campaigning for a drug-free society. It is never possible. You know? So there are certain principles that can align harm reduction. One of them is respecting the rights of people who use drugs. But the fact that you use drug does not prevent you from enjoying your basic human rights. We realize that even sometimes some of the drug policies, when it comes to drug control, the burden of proof is put on the person who is using the drug, so that somebody can just get up and put on you that you are using drug, and the law changes that you have to prove that you are not using drug. That is not fair. I mean, currently in Ghana, we are talking. I mean, we are having election petition in the court, and one of the big issues that is coming up is a burden of proof. One, if you are alleged, then you must be able to prove your case. You don't have to follow another person. But unfortunately, when it comes to drug use, we kind of take people's human rights from them. We are saying that one of the principles underlying harm reduction is respecting the rights of people who use drugs. Then there's a commitment to evidence. So that's what they are saying. There's the harm reduction policies and practices are informed by a strong body of evidence that shows interventions to be practical, physical. Sometimes they are safe and cost-effective. Very safe and cost-effective. Because sometimes we don't waste much time on this, but there's commitment towards social justice and collaborating with networks of people who use drugs. So now one of the principles they are using is that you can't, nothing for us without us. So you can't make policies for drug users or people who use drugs without involving them. So these are some of the principles. So that's how come even in South Africa there's a big organization like drug users, it's not, they do a lot of advocacy. So that's what we are saying. That even in advocacy, those of you who have CSOs, if you are in that field, then you must have some of your staffs who recognize or identify themselves as people who use drugs, because you can't sit in your office, you don't use drugs, you make policies and interventions for people who use drugs. Then the key issue, I mean, Charity spoke about this, meeting drug users where they are. you know. So I have a problem with rehabilitation facilities that require drug users to abstain. If you are saying that substance use is a disorder, people could use it to the extent where they have challenges with it, and it's a condition or it's a disease, then why are we asking people to cure their disease before they come for rehabilitation? Doesn't make sense. The person is having challenges controlling his drug use. If you are saying that the person should have stopped, if the person has stopped and the person is successful, then why is the person coming for treatment anyway? You know, that doesn't make sense. The person is in a rehabilitation facility. The person finds a way to jump or go out and to go in. So the person can accept the person, meet the person where they are. That's what Charlie is talking about. The person is using, meet the person where they are and help the person go through it. Don't sack the person. You want the person to go and die. That doesn't make sense, you know. So these are some of the things. So harm reduction, I mean, one of the principles underlying harm reduction is the avoidance of stigma, and sometimes the use of language, stigmatizing language which perpetuates harmful stereotypes like addicts. Whereas like somebody is clean. What do you mean? So if you are clean, doesn't mean somebody is dirty. So such words are very, very critical in our advocacy. So young students, when you go out, we are encouraging people to use the first person principle. People who use drugs, people who are having this condition, but not what addicts and stigmatizing words. So just like I told you, with the first one I've been mentioned already, and the second one, I mean, as we go out there, I mean, for every drug use treatment, for substance use disorders, there's two major outcomes. We tend to always focus on only the one, which is the abstinence. But it's not everybody who wants to abstain. Some people want to reduce their drug use. And in fact, for those of us in the mental health field, we see that somebody is having a disorder when the drug use affects the person's socioeconomic, whether they are their work, their family responsibilities, their social responsibility, and other things. If the person has a disorder, the person comes for treatment, and we are able to reduce the drug use in the person, and the person is able to function, is able to be productive, goes to work and performs and meets his targets, is being responsible in the house. I mean, a lot of people drink and take and use other drugs, and they are doing well. So the person has a disorder. Don't always insist that the person should be asked to abstain. Or abstinence should not always be the goal. Some people want to have what you call reduced use, and they should be encouraged. Then goals of harm reduction. So because of time and other things, so I'll not bother you too much with some of this. But keep people who use drugs alive and protecting their health are the most urgent. In fact, when it comes to harm reduction, we're not talking about for harm reduction principles. We really don't talk. We don't really. The principle here is not about. The principle here, there are certain things that people want to count, but when it comes to harm reduction, that is not the priority. It's about we saving the person being productive and good to go, and not about the person not stopping drug use completely. So harm reduction is also talking about not only treatment, but also some of the policies, the laws that are criminalizing drug use, so that young people are sometimes criminalized and arrested. You know, so if you imagine that sometimes you are going for a teacher training course, or you are going to a school. I mean, in Africa, they give you a form for you to fill, and most of the time they want to know your criminal record. So you are saying that by criminalizing drug, we are putting criminal records on our young people. I mean, most of you might have heard about the fact that all the former President Donald Trump, all the previous U.S. presidents might have had brushes with drugs. As they were arrested, they would have had a criminal record, and they wouldn't have been able to assume the high position of the United States. So we also have to advocate about policies that try to prevent human beings from enjoying their full human rights. You know. So because of time and so I mean, basically we are talking about the goals of harm reduction, and that offer opportunities to approaches that seek to prevent or end drug use. As we are doing the advocacy, we also have to advocate that prison sentence is not the only way. So there could be other ways, civil ways by which we can encourage our governments and lawmakers to think about, not only to put people into prison. It doesn't work. So I want to just speak briefly about harm reduction and politics. So sometimes we can use even harm reduction in our political atmosphere. So like we are going for voting. We want to know which of the political parties favor harm reduction principles, which of them involve drug users in their policies, which of them consult with people, which of them gives us space to go to engage them and talk to them, and which of them are able to listen to us and implement evidence-based policies. Like in Ghana, we have two major political parties. So I'm telling people that you weigh the two evils, the two of them, which of them are more likely to listen to us and implement harm reduction principles. So there are a lot of, we've spoken about most of them, but a few of them that I want to talk about. I mean, in the US, okay, so one, you're talking about what? Evidence-based drug prevention interventions. I realize that in Africa, most of the, apart from probably South Africa and some few other countries, most people are not investing money in drug use prevention. There's evidence-based. I mean, you don't just go to schools and go and tell people that, oh, I've been using drug and I've recovered and these are my challenges. That is not evidence. Or say that stop drug use, that is not evidence. Or there's one popular one that came up, I mean, from the US, I've forgotten the term, but there's so much evidence that some of these things does not work. So there's evidence-based prevention that governments can invest money into them, that children, even from primary school, can be taken to, even families can be taken through certain processes that will strengthen and prevent drug use. And also, I mean, Doctor and Charity spoke about methadone and buprenorphine, opioid substitution therapy. In fact, these are the gold standard for opioid use disorder. Then we're also talking about the use of naloxone. Naloxone is to reverse overdose. So we know that this person is using a drug. We teach people around the person to go to administer the naloxone. So when the person overdoses, the person can, we can give the person the naloxone to reverse the overdose. Then among other ones, we're also talking about driving under the influence measures. It's also a harm reduction. I mean, it's not so common in Africa, but some of the things that we can do on holidays, the police can mount driving under the influence checkpoints and check people who are over. If they found you to be too much drunk, they will ask you to, I mean, not to really to arrest you, but to stop you from driving. And sometimes you even encourage some of our young, you go to party and you're talking to your friends. When you let that a friend has had too much to drink and call the person not to drive, let the person park the car and let the person probably order a car, Uber, boat to the house. These are harm reduction principles. Then these days, and new cars are coming in that are fitted with things like breathalyzers. So that people who are living with something like alcohol use disorder and they're having difficulty controlling their alcohol consumption, their cars are fitted with something that before they turn the ignition on, the system checks their alcohol content. When it's at the best setting threshold, the car will not respond. The ignition will go off. These are all harm reduction principles that we need to be aware of and encourage our government to look at. So, you know about the controversial like simple, I'm not talking about it. The safe injection room, one of the advantages there is that when you create that safe rooms for people to come and use drugs, we have professionals, we have nurses, doctors, and other people on standby. So in case there's an overdose, it can be reversed. And sometimes when they are leaving there, they hand out flyers, information that could give them more education on their drug use. So these are some of the advantages that come with policies like safe injection drug rooms. Then we talk about the legal regulation of drugs. So like cannabis, it is possible that cannabis could be regulated based upon the THC content. So when you go to a place like Holland, in their coffee shops, the THC content in the marijuana that they sell at coffee shops, there is no go beyond a certain level. The THC in a typical coffee shop in Holland will not be more than 13% of THC. But in Africa, what do we see? People are just using drugs. They don't even know the content. So we are seeing that when you do legal regulation of drugs, people will be able to know that this substance that I'm taking, this is the level. The level should that like the alcohol and the whiskeys. I mean the beer, the whiskeys. You know the whiskeys, the alcohol content is high. The price is also high. But the beer, the price is not that high because it's low. The alcohol content is low. So these are some of the things we are advocating people to be able to use. But I have to also emphasize the fact that for adolescents and young people, there's no safe drug use. In fact, even though we are educating people on harm reduction principles, we don't want young people to use drugs because evidence shows that adolescents, your brain is developing. So by using drugs at that period, the drug has the potential to delay or retard the development of your brain or even hijack the brain reward system. So we are saying that for adults who are using drugs responsibly, that should not be anybody's concern. But for young people, the objective of advocacy is to delay their drug use as much as possible. To delay it. So when they get to their mid-20s or late 20s and they are using drugs, by then we know that the brain has finished developing. So these are some of the things we need to equip ourselves with as we do our advocacy. So I've spoken about this already. So thank you very much. And if there are questions, we are willing to take them.
Hello. Hello, sir. Thank you so much, Mr. Samuel Hanu, for that wonderful section. And yeah, questions. Yeah, thank you so much. So questions is next. So audience, if you have questions, you have contributions and additions, this is a time for us to share our thoughts together and learn from ourselves. And right, we have Ms. Maria Goretti here, we have Rosin here, we have Mrs. Dennis here, like a lot of knowledgeable individuals are here. So if you have questions, feel free to lend your questions out, and I'm sure you have awesome responses to them. So feel free. We have the next couple of minutes to ask our questions and learn from ourselves, and contributions, additions, you are welcome in relation to the topic as panelists has spoke. So feel free, everyone. So I think I might need to open the floor and possibly start the conversations through some of the questions our participant has asked in the chat box. So, and I've seen some additions by some of our panelists, and I've seen responses from our panelists. I've seen asked questions from our audience, and I'll start with that from Minerva. She said she's curious. Can someone speak to why opioid substitution therapy is used instead of medication-assisted treatments? I imagine the terms are used interchangeably, but the use of either can be stigmatizing. So I think there was a response to that. Mr. Jerome Ivano said, hi, and thanks for the presentation. My question, how we can do to have a better community involvement? Thanks for the question about cannabis. We need to legalize its use and decriminalize all drug users. How we can include harm reduction approach inside the drugs law, we need to protect our outreach workers. Cannabis is used for spiritual reasons too. Rastafari. Okay, thank you. Yeah, then Wahab Ibrahim asked a question, a fantastic one. He said, my question is that you said prisoners have a high rate of HIV hepatitis C with 13.1%. Is there a linkage that the men or female inmates copulate, or out of the world people don't check their health status? Then Will Williams says, what is harm reduction and abstinence mean to you? And what are the strengths and weaknesses of having them? Okay, yeah, thank you. So and I've seen responses by our panelists and our participants to the questions. So I would assume there is no question and no remarks from our panelists. So I would love to have my colleague, Rosine Downs, to say something.
Okay, Rosine should be on.
Okay, I think she's having issues with internet. Yeah, we also have Mr. Anonso Maduka, who is the General Secretary for the Community Intervention Network on Drugs in Nigeria and one of our top harm reduction experts we have in Nigeria, and is also here. So I feel most of my colleagues here should feel free to ask questions. We have our mentors, our guardians here, so they'll be glad to shed more light on anything we have that isn't clear to us. So let's be free to ask questions, and anything that hasn't been clear to you in the past, you are free, you can ask. That is the reasons why we have these trainings, to help improve our advocacy skills and knowledge. So feel free to ask questions. And Mrs. Maria Goretti, do you have any contribution from your end? Likewise, Mrs. Benis. Mr. Anonso Maduka, do you have additions? Feel free to add them so we can learn from you. That is why we are glad to have you here.
Okay, so Maro.
Yeah, I just said if you have anything to contribute in regards to harm reduction in the West African context.
Not really. I think the panelists have done a great job to the topic, and honestly, I think they have exhausted all that there is to actually discuss, and I think it's pretty refreshing to hear about the situation in Africa generally. I want to believe that a lot of the arguments that are always raised by a lot of policymakers and government officials has been the moral arguments, as we have always heard in terms of harm reduction. Because I remember some time back where a parliamentarian told us that how on earth can he encourage the giving of needles and strangers to persons who use drugs to inject themselves. It is an indirect way of encouraging drug use. But of course, sometimes as advocates, we need to go beyond that, those rhetorics and make the argument that, of course, government will want to see what kind of benefits are they going to drive in implementing needle and syringe program, for example. So of course, like I indicated in the chat, we need to raise the argument of the cost benefit analysis, where you make government understand that how much does government put in place for antiretroviral medications for people who have HIV/AIDS or hepatitis B treatment and C. If the government sits back and does, and they do this analysis, you realize that it is better to be able to prevent new infections among these people and save the state of a certain amount of money that it's not going to cost so much to provide needle and syringes for these people to use, as compared to antiretroviral medications you're going to import into the country, or hepatitis C medications or hepatitis B medications for these people. So if you do those analysis, sometimes they sit back and they realize that, of course, you have a point. It's not just about the needles, the moral argument of it, but of course, you are also being able to prevent new infections among these people and put them in a healthier state and also save some money for government. So I think sometimes we need to go beyond that and make these arguments, and which the panelists have already discussed extensively on that. So as advocates, let's see how we can always make these arguments in supporting this. And like Charity rightly said, in terms of the evidence, I think we need to echo that strongly as civil society. There's so much evidence on the benefits of harm reduction, but we are failing to see a lot of this coming up for government to see. And I've always used Senegal as an example, where Senegal, to get to the stage in which they are with harm reduction, it took civil society to point to government that these statistics you are telling us about HIV infection is not correct. So they took the extra mile, got the evidence, and told government that this is what is on the ground, before government could believe this and came in to support a harm reduction. So I've always argued that civil society, we need to document the little successes that we have chalked and make so much noise about it. And I believe that as we make this noise, we will be able to make inroads like our great panelists have all argued. And we will definitely get things happening in Africa and in West Africa as a whole.
Thank you very much, ma'am, for your contribution.
Thank you.
Yes, ma'am. Ms. Bernice, do you have any contribution also before we round up? Oh, she's muted. Luis, can you please unmute Ms.
Yes,
Bernice?
absolutely. I did also want to say, what's it called? So first, let me bring in Bernice. Apologies. There you go. We do also have one question waiting from Ahmed.
Ramon, okay, yeah. So after Mrs. Bernice, we have Ramon. Ahmed Ramon.
Hi, Moro. Hi, Charity and Catherine. So nice to see you guys. That was a good presentation. I was just following up and trying to type in the question so that, we build up what we are trying to do. I'm also excited to see more and more advocates able to argue in this field. Generally, what we see is an increase of the number of people becoming aware of harm reduction, which is a good thing for us. We are seeing a lot of evidence coming up. It's something that we should be happy about. But what we should be cognizant of is that Africa is still very behind when it comes to some policies that is really, really letting us down. We are seeing the America and Europe, they are on the road to decriminalization. But as we are still stuck, there was one listener who asked about decriminalization of cannabis, and it's all about our policies. Africa is predominantly prohibitive, and it has given us a lot of issues. It's all an American war we are fighting, but still it's in our space to push for some of these laws. West Africa, East Africa, South Africa, the different blocks, we have to come together and collaborate as advocates and civil society so that we're able to push for some of these laws for the benefits of our people. Thank you so much. I really appreciate what you're saying. I'm so happy Catherine is in this space. I'm happy to see Charity. Thank you so much.
Thank you so much, Ma, for your contribution. So Ahmed Ramal, you have the floor. Oh, it has to be unmuted rather. Ahmed Ramal, Luis?
Yeah, I'm muting him right now.
Yeah, thank you.
Yes, thank you. My question there is, I was thinking, if we support addicts with giving them needles so that they can stop spreading diseases to some other addicts, I think it will only make them happy because they get new needles and they can keep using. Because I was an addict before. Now I know that nature of the addict's mind. If someone come and support them with something like that, they will love the person and then they will keep on using center right now, which is operating for 2 years now. If I go to town, there's a lot of addicts who would want to quit using the drugs. Now I really want to quit and stop the using of the drugs through the recovery. That was my question.
Yeah,
thank you.
Yeah, thank you so much, Hamed Ramal. Before I give the floor to our panelists to answer that question, I would first like to make a correction on the language use. We are very determined and very strict with the words we use to qualify people. We are against using the word addict. We prefer you to say drug users or some other better used words. So we don't support the use of addicts in SSDP. And I'm sure most of our panelists would also subscribe to this. So I'll give the floor to our panelists if they have the answer to your question. Thank you.
Can I attempt to answer? I mean, that's a very good question. I just wanted to say, I think it goes back to what I said about supporting drug users holistically. So when drug users come into programs and harm reduction programs, services of middle exchanging programs and only OST, they receive psychosocial services as well. So you're not only going there to receive a needle or receive your dosage of methadone, you get to socialize with other people, with other drug users, as well as the staff that work there. And at times, I'm only going to speak from the experience that we've had in South Africa. So in our programs, a lot of the people a lot of the drug users that come into the program tend to become peers. And so not only is it an incentive to not necessarily get off using drugs, because the point of harm reduction is not, abstinence is not always the end goal. And as I mentioned, it's about meeting a person where they are. And so if a person wants to stop using, they will. If they don't, we can't force them to stop using. All we can do is support them in their journey to recovery, or maybe not even wanting to get off substances, because some people function when they are on substances. And so we need to start changing our mindsets on, it's basically like a person that needs medication, like when someone needs their insulin. If they don't want to use it, I can't stop a person that has diabetes from stopping their insulin intake, because that's how they function. And so if they need it, they will use it. If they don't want to use it, they won't. And so we need to start thinking like that towards people that use drugs, that they are humans. They can make their own decisions. If they want to, they will stop. And if they don't want to, we need to respect that and offer them an environment that supports their decision to live a healthy life, or do whatever it is that they please. We live in countries that have constitutions that should prioritize people's human rights. And so it is our responsibility to ensure that people's rights are protected, no matter what they decide to do with their lives. So I hope that answers your question.
Thank you very much, Charity, and thank you very much, our panelists. And I think we have one more contribution from from Mrs. Bernice. Needles and syringes program do not furnish status. It is meant for exchange people who are already using it. Thank you so much, Ma, for that. And I would like to appreciate our panelists, Dr. Catherine Mwangi, Charity Monareng, and Mr. Samuelano. Thank you so much for your time. And thank you so much, Luis Montoya, for your time for making this section really orderly and well organized. Thank you so much for everyone for participating. Mr. Noso, Rita Motoye Gatoye, thank you so much for your time. John Odek, Lawal Kamel, Eddie Michel, Minani, Alaji Conte, colleague from Sierra Leone. Thank you so much, everyone. And Ahmed Ramol. We really appreciate everybody for finding time to attend this section for this month. And we hope you join us again next month. Thank you, everyone, and do have a lovely night. Ashanti Sana and Medase. Yeah, thank you so much, everybody. Bye.